Hello, I'm Gary Carruthers, Director of the Domenici Institute at New Mexico State University. When Senator Domenici donated his papers and established the Institute at New Mexico State University, he had two real interests: the promotion of entrepreneurship and small business, and also the discussion and development of good public policy. In collaboration today with the National Federation of Independent Business, we have a special guest to talk about a topic that is both associated with small business and public policy. And here to introduce our speaker is Minda Mcgonagle, a graduate of the University of New Mexico, which we will forgive her for. She also is a small business person in Albuquerque, New Mexico, and has been the director of the National Federation of Independent Business since 2009 in New Mexico. The National Federation of Independent Business has chapters in all 50 states and, of course, promotes the prosperity for small business. Would you please welcome Minda Mcgonagle of the National Federation of Independent Business.
Thank you very much. Thank you very much. We are so pleased to be here and have this opportunity. As Dr. Carruthers said, we are the small business advocacy group. In fact, NFIB is known for being the largest small business advocacy group in the nation. One of the things about NFIB, which is very fitting for small business, is that how we establish public policy is by the votes of our members. So unlike organizations that may have a board or whatever, our members decide what their most important issues are and what our perspectives are. Because of our hard work in the states and in Washington, we made Forbes' recent Washington Power 25 survey as the most influential business organization up in Washington, D.C., in part because of our presenter today. Dr. Bob Graboyes is Senior Fellow for Health and Economics at the NFIB Research Foundation in Washington, D.C. In his role, he analyzes federal and state health care legislation from the perspective of small business. He also teaches health economics in master's and doctoral programs at Virginia Commonwealth University, the University of Virginia, and George Mason University. Previously, before Dr. Graboyes joined us 6 years ago, he was Chase Manhattan Bank's chief economist for sub-Saharan Africa, and he also was an economist at the Federal Reserve Bank of Richmond and associate professor at the University of Richmond. One to travel the world, in 2000 and 2007, he was visiting scholar in Central Asia. He has a PhD in economics from Columbia University, master's degrees from the College of William and Mary, Columbia University, and Virginia Commonwealth University, plus a bachelor's from the University of Virginia. Outside of his work, he plays piano and guitar, jazz, classical, and Latin, enjoys speaking foreign languages, Spanish, French, Portuguese, and a little bit here and there of some others. And most importantly, he loves New Mexico, and he has recently been enjoying our state with his lovely wife, Alana, and we are hoping to get him here many, many more times. You can see his recent writings at nfib.com/Dr. Bob, as he's affectionately known in NFIB country. I am confident that you are going to leave here today better informed, with new mindsets, and well entertained. And again, we are so appreciative to be able to participate with the Domenici Institute. Without any further delay, Dr. Bob Graboyes.
Thank you so much, Minda. Well, thank you, folks. Thanks, everybody, for coming, and thanks especially, Dean, for allowing NFIB to do this program. As Minda noted, we think of ourselves as the voice of small business in America. We have 350,000 businesses across America, mostly very small ones, some larger ones, that belong to NFIB. And since the 1940s, this really has been the premier voice for small business in the country. Today I'm going to be talking about healthcare. Healthcare has been, for at least 25 years, the #1 issue for small businesses across America. We know this because the way NFIB operates, we're not a bunch of guys in Washington telling the businesses what we're going to do and what they should think. Rather, we're a membership organization We extensively poll small businesses across America saying, what's important to you and what would you like us to do about it? And there's a lot of back and forth, of course, but that's kind of the way we operate. And again, for 25 years, they've been telling us health insurance costs are the biggest problem for small business. Now, see, Minda said that you'll learn a bit today. I'm also going to wear my professorial hat today. I teach at a couple of universities, and most of my students, let me point out, while I have taught undergrads, I have taught in business school, MBA program, but most of my teaching is in health economics, and I teach doctors, nurses, healthcare administrators, hospital administrators, insurers, and so forth. Teach them all about healthcare, and what I tell them on the first day of every semester is, my goal in the class is 6 months from now when we finish, I want you to know less about healthcare than you know today. The reason for that is, and I can quote probably the earliest American comedian, comic writer, a fellow by the name of Josh Billings, who famously said something on the order of, it ain't what you don't know that's the problem, it's what you do know and just ain't so. And today I'm going to wear the professorial hat a little bit and talk about what just ain't so. And the purpose is to tell you how hard it is to do health insurance or health care policy. Now, everyone has their ideas. People have a very strong notion of what we ought to do in health care. And a lot of it, I will argue, and it doesn't matter whether you're talking someone from the right or someone from the left, the problem is they have a lot of preconceived notions that kind of get in the way of thinking about what the real problems are. From NFIB's perspective, the big problem that small businesses complained about all of these years is high cost. Healthcare has grown enormously as a percentage of the U.S. economy, and for small business, it has been an especially troubling piece. It has made it very hard for them to function, hard for them to hire people, hard for them to build their businesses, to grow, and to make the economy of the U.S. soar. We have other problems. We have a lack of coverage. We have tens of millions of people who do not have health insurance, and most assuredly, that's a problem. Although we will say that most of the reason for that is the high cost. We also have some uneven quality. But let me start with a couple of ideas just to debunk a few things. I'm just going to mention one or two issues that I talk about with my students, as well as with people in Washington, D.C., where I live and work. Again, people from the left, from the right, have their ideas about how we should reform health care, and I would argue that in all cases, or most cases, they tend to be operating from things that may not be so. When I talk to my friends from the left, they will typically talk about, well, how come we can't do things like in Europe? Europe, they will say, has better care than we do, and it's a lot cheaper. And so let's just photocopy one of their systems, bring it over here, and kind of wipe our hands of it, and we're done. I can briefly, and again, I have 6 months to do this with my master's and doctoral students. I'm going to do this in about 3 minutes here. I can illustrate the problem with that assumption by talking about one of my particular students. She was a physician, a brilliant physician. And in our class, we were talking about what drives the costs in America in healthcare. And we were talking about the fact that it's really the advent of technology. Since 1965 or so, around there, our capability of delivering medicine and delivering it very well and very expensively has gone beyond what anyone could have imagined those years back. This doctor, this student of mine, was talking about her son. He was premature, extremely premature, to the extent that he made the medical record books by surviving. He was, I forget what his weight was, but it was something in the order of 1 pound, and it was a miracle that he survived. And she was saying in the class, of course, it cost $500,000 to save his life in the neonatal intensive care unit. She said, we, of course, think that $500,000 was well worth the expenditure. He was at that time in his 20s. He was working on, I believe, a PhD in computer science. He was athletic. He was healthy. They had been blessed with decades of a son that in any previous period in human history they could never have kept. And I said, $500,000. Well, I said, what was his prospect? What was the probability of survival at birth? She said, well, the doctor said it was less than a 1% chance. I said, in that case, in dollars and cents, I said, without meaning any implication of what should and should not be done, he wasn't really a $500,000 baby. He was really a $50 million baby. The reason being, in order for him to live, you had to roughly, on average, treat about 100 children like that, 99 of whom would never survive, and the one that made it through. And so I said, so in a real sense, it probably cost $50 million to save your son. And I said, and I'm very proud to live in a country where we have that capability and where your son had the chance to live. But it does cost a lot of money, and when we're worrying about what can we pay for in the future, that is the big question. So let's compare it, for instance, with Europe. This is what I'm going to tell you is true of many countries, but in particular I'm going to talk about Switzerland because I've seen the figures written. In Switzerland, her child would not have survived because the rule there is if a child is born under 30 centimeters, they just don't treat. It's the end of the story. So those 100 children would not have been treated. Furthermore, you will often hear, again, from people advocating, why don't we do things more like Europe? Well, they will frequently say, in Europe, the infant mortality rate is lower than here, and yet they spend less. Well, I've just told you one reason they spend less. But as for the data, the infant mortality rate, in Switzerland, those children who were born, lived very briefly, and died, by and large, would never be registered on the books. The way they keep the records there is if the child dies within a certain period. In some countries, it's 1 day, 2 days, 3 days. The doctor writes stillborn. In other words, never lived, never died, never impacts the infant mortality statistics. And simply, if you changed their record keeping to match ours, the whole difference between the infant mortality rates in our countries vanishes. So in one brief little story, one that frequently chokes me up when I talk about it, remembering my student, we see that one is on shaky ground when you simply point to another country and say their care is better and they spend less. Now again, none of this tells us what we should and shouldn't do, nor does it tell us that we don't have problems. When I talk to friends on the right, they have their own memes, their own sort of habitual stories to tell. One of them is very frequently, well, our big problem here is it's a matter of personal responsibility and having skin in the game, and what we need is more preventive care. What we need to do is have everyone think more about their health, live better, exercise, don't use drugs, don't smoke, don't do this, have a bit of skin in the game so that you actually, if you have expensive illnesses, you're going to have to somewhat feel the pain of it. And so what we need is more prevention, eliminate a lot of the expensive diseases so we'll live longer and live better. And that is an admirable goal and one that I share and one that we ought to do more of. However, sort of the dark secret of that story is taking better care of yourself and preventing illness does not lower our global healthcare spending, it raises it. Now again, I spend probably a week, 2 weeks with my grad students talking about why that is, but fundamentally I can sum it up very quickly in pretty crass terms. If you take good care of yourself, you're going to live long enough to have some really, really expensive diseases that come typically late in life. Cancers, heart illness, Alzheimer's, those things. More than once I've been at meetings in Washington and heard someone say, probably correctly, if we want to cut healthcare costs, convince everyone to smoke. They'll die 10 or 15 years earlier and you'll miss out on all the really expensive stuff. But of course, that's not what we want. Now that brings us to 2010, when Congress passed and the President signed one of the most significant pieces of legislation in American history. And the goal was to improve our healthcare system, to deal with costs, to deal with coverage, to deal with quality. My organization, NFIB, thinks, first of all, that we badly needed reform, but secondly, that the particular reform that was passed was a disastrous piece of legislation. That we think, first of all, I'll bring it out right at the beginning, we are the principal litigant. The case that will come before the Supreme Court to throw the law out, the Supreme Court will hear it in March and probably decide in June. The case began with 26 of the 50 states joining together to fight the law. NFIB joined it, and at this point, the lawsuit for circuitous reasons is now known as NFIB v. Sebelius. So either way, whatever the Supreme Court decides, NFIB will have made history in this. And I do have to stress, I've said my friends on the left and friends on the right, and I mean that quite sincerely. I told a friend of mine recently, someone with very opposite views of mine, I said, if I ever get to a point I can't sit down and have a good civilized lunch with you, it's time for me to leave Washington. And I sincerely believe it. So I'm saying the best of intentions were out there. But what's wrong with this law? Since we're in a university setting, let me just ask real quickly, how many of you are students? How many faculty or university employees? And how about business owners? Great, okay, we got a good mix there. I'm going to frame this in terms of a college or university. And it does not really apply to New Mexico State University, where all is well and everybody's happy. So I gave this little piece of the talk at another university in the Washington area where nobody's happy. But anyway, let's say you've come and you've got some serious problems. And the problems I'm describing are things you will hear about people talking about American universities. Tuition skyrocketing. Many people can no longer afford a college education. Graduation requires you to take a lot of courses that you don't like and that you don't think are particularly valuable to you. And yet, when you finish college, you find out there are gaps in the curriculum that make it very hard for you to get a job. You're underqualified. You find that the campus resources are scarce. The admissions office has to reject thousands of really good applicants that you wish could be here. And the college administration, and this clearly is not here, is robotically inflexible. So, it's time for university reform. And I come up with a proposal. It's a 2,000-page, I'll call it Student Protection and Affordable Education Plan. Now, for those of you who that isn't ringing the bell, the actual healthcare law is called the Patient Protection and Affordable Care Act. So here's my plan. See how you like it. We'll immediately increase the student body by 1,800 people, 10% in 2012, but we're not going to hire any new professors, sections, we're not going to have any more classrooms, no more housing, and no more. However, we will form some faculty committees to study how we can improve the situation by the year 2037. We're going to have a 9% increase in tuition effective immediately. Any student who's receiving a scholarship, their parents' IRS 1040 form will be sent to each of your professors. If your roommate's family income is less than $140,000 a year, you will pay an extra $2,000 per year in tuition to kind of help out your roommate. On the other hand, you are not legally allowed to see your roommate's family's tax information, so you're just going to have to assume that he's telling the truth. The dean can exempt any particular student from some credit hours. So the dean can simply say, well, I don't know what it is, 120 credit hours for graduation, but you only need 90, and you can get by with 60. Why? I don't know, he doesn't have to tell you. And he says, well, if you want to apply for this, you can apply for it. Fill out these 20 forms and send it to me, and I'll decide. So on what criteria? Well, he doesn't have to tell you. Does it sound good so far? All right, now we're going to get into, you're going to have a mandatory 10-page weekly essay on academic progress, on your academic progress. Now, if your essay is substandard, there are going to be academic and financial penalties. but they're not going to tell you what the penalties are until after the fact. The VP for Administration and Finance can increase tuition and fees any given time for any reason. The dean at any time can increase the number of credit hours required generally for graduation, though of course he can exempt you if he wants. And also, by the way, the last two rules you've heard only apply to students in the School of Arts and Sciences. So, are you all in favor of this? I don't see a whole lot of enthusiasm. So my question then is, what? You're opposed to university reform? Well, that's what we get a lot of. We're opposed to the PPACA, the law that passed in 2010. People say, why are you against healthcare reform? And the answer is we're not. We're extremely much in favor of healthcare reform. What I've just described to you, those bizarre characteristics of university reform that sound pretty awful by design, are absolutely analogous to what small business is going to deal with because of the 2010 healthcare legislation. First of all, it's going to add 30 million new people to the insurance rolls. That's 30 million, roughly 10-15% increase in the number of people with health insurance in the country, and all those people are going to be wanting health care. Plus, for the rest of us and for them, it sets up a fairly lengthy list of preventive services, and it says everyone is entitled to these without any copayment out of their pocket. So essentially, you're going to have access to several dozen new services for free every year, just for the asking. Now what this means is 300 million people with quite a bit of new incentive to go to the doctor and spend some time, and 30 million people with a whole lot of incentive to go. But the law does nothing. It does not increase the number of doctors, nurses, hospitals, or any other resources. It does set up some programs that say, well, let's think about this so that 15 years from now, 20 years from now, it'll be better. But nothing soon. Small business was told over and over, we got to do this because otherwise costs are going to rise faster. The fact is, the year before the law passed, healthcare premiums went up 3%. In the year after, they went up 9%. And I think they're going to be going up. That's going to be a regular occurrence. The law, in strange ways, violates your privacy, everyone's. Three big provisions dominate this law. One, there's a requirement that everybody has to have insurance. Everyone, man, woman, child, just for the virtue of breathing. That's unprecedented in American history. The federal government has never said everyone has to buy something. We think that's a dangerous precedent in and of itself. But health insurance is expensive. You're telling people all over New Mexico, you're going to have to spend maybe $12,000, $15,000 a year to buy insurance. Well, a lot of people are going to have trouble affording that. So the law sets limits and says if you meet certain mathematical criteria, the law determines that you cannot afford it, and the federal government will subsidize you. They'll pay part or even all or close to all of your insurance bill. But for certain employers, if even one employee of yours gets one of those federal subsidies, and I'll tell you, you can be making a pretty substantial amount of money and get those subsidies. If one of your employees gets it, and you are a firm of 50 or more employees, you are then on the hook for thousands of dollars a year in penalty, kind of to punish you for that employee getting a subsidy. So what does this mean? This has a couple of things. First of all, if you're someone, let's say your family falls on hard times, your income drops, you suddenly mathematically are entitled to this subsidy, and you say to the federal government, I need the subsidy, which can be $10,000, $12,000, $15,000, depends, no one knows. But if you do that, the federal government's going to mail your boss information that says your employee is getting a subsidy because their family income, not the employee, their family income is below a certain level. Which means, in essence, it's going to alert your boss if your spouse suddenly has a drop in income, if your spouse leaves you, if some bad events happen in your household. They may be things that you are deeply hurt about, things you don't want the world to know. Nevertheless, Federal government's going to be mailing things to your boss, essentially telling them something's happened in his house. It won't say exactly what. Now, from the boss's side, there's a similar problem, which is if my employee suddenly gets a subsidy, and the mathematics are very strange of this. Normally, in most cases, if you went out and got it, the increase in my penalties could be $0, it could be $2,000, it could be $3,000 a year, or in strange cases, but not that strange, the fact that you go out and get a subsidy could land me, your employer, with somewhere beginning at $40,000 a year in penalties and going up. However, I don't have any way of knowing what your household income is. And the law is very explicit. I can't even ask you. I don't have that right. So I got to go trust the fact that you are going to the federal government and honestly depicting your family's income. And it is literally true, that in some cases I could have an employee, if I were an employer, I could have an employee who has a spouse, who has an elderly uncle who moves into their house, and because of the way the formula is calculated, both by income and family size, the elderly uncle moving in the spare bedroom could trip the switch. I could get thousands of dollars in penalties. I don't know why. I can't ask why. The only way I can find out why is to go to the IRS and say, I think my employee is doing something wrong. So I think it creates the potential, at least, for very serious problems. And I'll have to say, the IRS knows that's a problem. They've been very forthright about it, saying this is serious, we need to do something about it. I just don't know that they're going to be able to. The law requires small businesses to fill in all sorts of red tape, all sorts of new mandates. It allows the Secretary of Health and Human Services, at the stroke of a pen, to require new benefits. Can simply suddenly say, now some states, this is true, some states require every insurance policy has to cover hair transplants. Others, and some of the mandates are more serious, more sort of pull the heartstrings, autism benefits, lots of different things. And they're all expensive, and individually they're all good, but collectively they're expensive. Suddenly the Secretary of HHS has the capacity under the law to simply add these things at will, and they can only be overturned by an act of Congress. And by the way, the Secretary of HHS at present recently said, I'm not going to deal with this for a few years, we're going to pass it on to the states to deal with, and no one knows whether that's actually doable, what the implications are. Those of you, I don't know if there are any people in here involved in information technology. One of the things we are deeply worried about is that to manage all these bits of information I've told you, that's an enormous amount of information. If you're working for her, and I'm the federal government, I have to know how much she's paying you, how much, if you have a spouse, how much the spouse is getting. I have to know your immigration status. I have to know whether you're getting Social Security or Medicare or Medicaid. To manage this is going to require the merger of the data feeds from Department of Health and Human Services, Department of Labor, Department of Homeland Security, IRS, Social Security Administration, all 50 states, Medicare, Medicaid, CHIP, and all the private insurers. And quite frankly, no one has any idea whether this is doable, and it's got to be up and running by January 1st, 2014. The National Governors Association, which is, as we know, bipartisan, has sent out a cry for help in my interpretation, saying, we don't know if this is doable. If everything works right, we don't know if it's doable. But in fact, it's not working right. The federal government is lagging behind in its timing. The federal government is missing its deadlines. They're not providing the necessary information. So I've just told you a bit about why we are deeply worried about this particular law, and it does not imply that we're against health care reform. So NFIB has, and I'm not sure if you were handed some materials, but NFIB is now saying, okay, we want this law gone, but whether it stays or whether it goes, we have to really fix things. And we've begun rolling out proposals for what we would actually like to see, because if it goes away, we're still back in the troubled spot we were before. And so we've rolled out, just as a starter set of solutions, if you go to nfib.com/solutions, some changes to the tax code to equalize the fact that if you get your insurance through your employer, you get a tax break. If you go out and buy it on your own, you don't. What that means is it strips you of your motive to be an informed consumer and, and to know, you will know, oh, look, I'm paid to know something about health insurance. I know more about my computer than I do about my health insurance policy. Why? Because when I spend money for a computer, I got to know whether it's good or bad and what it does and what it doesn't do. Health insurance policy, employer says, here it is. I don't have to think about it. We would like to see a move where employers could say, I don't want to pick my employees' policies, especially small businesses. They don't know anything about insurance. And they would like to say, I want to help my employees. I would like to give them some money on a pre-tax basis, just like big companies can do, and just like a small company can do if it picks the policy. And just say, look, I would like to give this money to my employees and let them buy the policy they want. And for that, we're going to need information systems that make it possible for a consumer to know as much about their insurance policy as they do about their computer or their car or their cell phone. Right now, big companies, labor unions, governments, they can merge people across state lines to pool the risks, to share the risks. Small businesses can't. They're locked into a single state. We'd like to be able to, if you're not happy with what New Mexico insurers are selling, we'd like you to be able to walk across the border into Texas and buy something they're selling over there. We do think it's absolutely crucial that we deal with the problems of people with pre-existing medical conditions. There are better ways to do it than this law did. We want people to be able to move around from job to job or periods of unemployment without losing their coverage. We want tools to allow consumers to be smarter. We do want wellness incentives. Prevention and wellness costs money, but that's okay. We want to be healthy. And there was nothing in this law on reforming medical malpractice. Now, I will say these solutions are just a starter set. That's all it is. We're going to roll out more as time goes by. But even if we get everything we want on this, it's only a small tip of the iceberg. There are two big things that are going to have to be dealt with. First is entitlement reform. You guys are going to be expected to pay for us guys whose hair is a little bit grayer. You're going to be spending, under the current promises, you're going to be spending a staggering amount of your working life just paying for stuff for us. And in fact, I think I'm quite safe in saying the promises that have been made under Medicare cannot be met. There aren't going to be enough of you, and you're not going to be rich enough to pay for what we essentially have promised ourselves that you would pay for us. That's got to be fixed. I'll give a very simple example. There's a urologist I heard speaking. She had a patient with with a problem. 2 surgical procedures were possible. One cost $60,000 or so. One cost about $2,000. Medicare and her patient, strangely, was an unusual case where the $2,000 was actually better for him medically. Medicare said, we'll only pay for the $60,000. We don't pay for the $2,000. She did it. She said, I'm going to do the $2,000 and mail the bill in anyway. And now Medicare is chasing her all over the place, saying, you need to pay this out of your pocket. That's just one small story. Medicare is filled with those stories. Medicaid has problems. We're also going to have a whole lot of conversations about how do we deliver care? If you need a prescription, do you really have to go to a doctor, or can a nurse practitioner write the prescription? If you need a hospital, do we need big general hospitals? When you go in because you broke your arm, do you really need to be subsidizing the cardiology wing, the cancer wing, whatever, or can we have little component specialty hospitals? How do we get more manpower? How do we get more doctors, more nurses? How do we move them to the places they need to be? These aren't going to fit on a bumper sticker. This is not something we're going to be able to pass one piece of legislation and be done with it and have a cheaper, better system. So we are really, whether this law stands or falls, and of course we hope it falls so that we can get busy right away in doing some real reforms, we have a long, hard slog. And with that, again, I just wanted to say thank you to all of you for being a great audience. Thanks to the Dean. And I will say a special thanks to Minda from NFIB, New Mexico, and to my wife for the wonderful time we've been having. And I will have to say, New Mexico, honestly, I don't say this in New Jersey or Delaware or wherever. New Mexico is our favorite state in the Union. We've been coming here for 20 years and deeply love the place. And with that, we can switch on in.
Dr. Bob, thank you very much.
Thank you.
Come on over and come over here and join me. And I would tell you this is a very robust economy in New Mexico and Las Cruces, and we do have real estate for sale, and that we can fix you up with a very nice home at a lot less money than you would spend in Washington, D.C. We have a wonderful university here that you can enjoy all the amenities, including a growing football programs even becoming more competitive. So we're pretty proud of New Mexico, and we're so delighted that you would come and visit with us. Now, the Domenici Institute has a tradition that we started 5 years ago with our first conferences, and that is to have students ask questions of the speakers. And so we have some of our students, I think they're all ambassadors from the College of Business because they had to come into school a week early. Our students have not quite arrived yet, but we have some excellent ambassadors from the College of Business who will ask you the first questions, and then if we have time later on, I've got some other people who want to talk to you.
Absolutely.
Okay. Good evening, Dr. Graboyes, Dean CRUCES. My name is Daniel Cueto. I'm an accounting major here at the university. And my question for you, Dr. Graboyes, is in some of your literature, you state that insurance markets need an adequate information structure for consumers to make intelligent choices. Do you believe that the federal government needs to create an entity similar to the Securities and Exchange Commission that would require health insurance companies to file reports that disclose their various insurance plans and their pricing?
Good question. I don't know whether I favor the federal government doing the whole job. We certainly need a better information infrastructure. I have a colleague at the University of Minnesota who writes extensively about this, and he argues that, and this is just one argument, I'm not saying I'm in favor, but he argues that we really already have mechanisms that could be used for these purposes, and that is the platform on which the credit card companies transfer vast amounts of financial data. Credit card companies are real good at picking up the fact that you've made a transaction. When I travel overseas, I roll my credit card in Kazakhstan, and the next thing I know, a couple seconds later, it's on my web page, no matter where I am in the world. If my wife wanted to check it, she could see that I had made this transaction. So we have information structures that are readily convertible to these. I do worry that if the federal government decides it's going to do it, it's not going to do it right. And I always like to think, what if 20 years ago you'd said, you know, we need a federal agency to design cell phones? What would they look like today? I'm afraid they might be 20 pounds with a big suitcase battery. You'd be walking around and you'd have a little crank and have to ask the operator to dial the number for you. So it's a big question, a good question. We certainly need transparency. You also get into questions about what kind of transparency, what do you need to know, and you certainly have to build in security mechanisms because this is some sensitive information.
Dr. Graboyes and Dean CRUCES, good evening. I'm an accounting and finance major, and my question is, with the goal of trying to drive down healthcare costs and make it a more competitive market, what would this actually do to the quality of healthcare?
Well, that's a great question too. We all want excellent quality, and there are open questions of what do you mean by quality. That doctor was talking about $60,000 versus $2,000. For most patients, the $60,000 is slightly better than the $2,000. And if you're one of those patients, you say, someone else is paying for it. All these kids coming out of school here are going to pay for it, so I'm going to go get that $60,000 one, whether or not I need it, whether or not it really is going to be markedly different. Look, in most industries, and I can give you a short, long answer. There's a book by a scholar by the name of Clayton Christensen called The Innovator's Prescription. As far as I know, it's the single best book I have seen on the mechanics of the question that you've asked. In every industry where there has been innovation, people have ultimately had to make hard choices. Do I need the very, very, very best, or can I do with something a little less, but way less cheap, less expensive? So computers. When I first started in banking back in the 80s, all we had was a shared Wang computer that cost, I don't know, 50, 60,000 bucks. And it couldn't do nearly as much as 2 or 3 of the apps on your cell phone. And what we decided, IBM came along and said, we're selling a device here. It's probably not quite as strong. It's not as engineered as powerfully as that Wang. It isn't going to last for 60 years. But on the other hand, it's going to be 1/20th of the price. And once the market zoomed over in that direction, then the quality improvements began occurring to the computer. One of the problems with our healthcare system is we do not have the mechanisms for innovations like that. We have all sorts of legal, technical, physical obstacles in the way of people innovating. And actually, if you really want to see what's happening, take a look at something called medical tourism. There are hospitals in India, Costa Rica, Thailand, a lot of different countries where Americans and others can fly to get cardiology procedures, knee replacements, dental implants, you name it, at a small fraction of what it costs here. And I once had lunch with the president of the American Medical Association, the top doc in the US. He had just come back from one of those hospitals in India. And I said, how was it? He said, I have never been in a facility that outstanding in my career. He said they're using all Toyota methods for management. They've got efficiency down to like nothing I've ever seen in this country. The training, the personnel was superb. And yet you can go over there and get these procedures for a fraction of what you pay here. I'm not saying run off and do it. I haven't faced that choice, and I'm not sure I would. But we need to look at what these other countries like that are doing. We have an awful lot to learn from them. And we have a lot of laws we're going to have to get rid of in order to get that kind of innovation.
Dr. Crothers, Dr. Graboyes, thank you for coming to New Mexico State. We appreciate you visiting us. My name is Max Hake, and I am an accounting and finance major, and hopefully one day a small business owner. And my question to you is, you said at the beginning that NFIB is a premier organization for small business. What is your definition of small business? How do you define that?
The name of the organization is National Federation of Independent Business, and our slogan is the voice of small business. So there's a little ambiguity there. To belong to NFIB, you have to have a business that is not publicly traded. So if you're listed on a stock exchange, we'll bid you bon voyage and wish you good luck in where you're going. Most of our members, 95, 96, 97% of our members are very small, have 8 to 10 employees. Some of them are companies with 1 employee, the owner and no one else. I think the average is in the 8 to 10 range. But technically, as long as it's privately held, you can join. Mars Candy and Bechtel Corporation are not members, to my knowledge, but they could be. But most of our members are small.
Hi, my name is Kelsey Campbell. I'm an economics major here. And my question for you is, given the risks and barriers that are existing right now faced with startups, is this healthcare reform just one more barrier for small businesses to enter into that?
Well, this healthcare law is about 100 barriers to it. This is one of the reasons our members are telling us, I am not growing, I'm not hiring, I'm not going to do anything. I don't know what it's going to cost to hire a new employee. And I'll often be, an answer that I'll get from people is, well, but that doesn't happen until 2014. But that would be coming from someone who hadn't run a small business. When you hire someone, you're not saying, you know what, I'm going to hire you, and if the healthcare thing doesn't work out, I'm firing you in 2013 before this thing clicks. My parents were small business owners, And my mother's 89 and still has relationships with her employees, the few who are still living. It is a very personal, very close environment. But right now, well, we've got one member who testified at our request before a congressional subcommittee. He's a lumber manufacturer in Texas. He's got 9 locations in different states, maybe in New Mexico, I'm not sure. And he's going to be hit by that employer mandate. Now, he's got about 450 employees. He has offered them health insurance all along. He used to offer it to them. None of them took it. His managerial level people said, we want the policy. His line guys, the blue collar guys cutting wood and loading it, whatever, said, we don't want it. And he couldn't do anything to get them to take it. So finally, he had to jump through some hoops to be able to offer it to his managers without running up against anti-discrimination laws, and certify that I'm not doing this because I don't want to offer it. They don't want it. Well, under this law, he's going to be, at minimum, he'll have to pay a penalty for not offering it. The penalty will be, for him, since he has 450 employees, it would be somewhere between $900,000 and $1 million a year in penalties. And if he were to buy them insurance, it would be multiples of that. And as he noted to the guys in Capitol Hill, I don't make that much. So that's more than my company's profit. So if I have to live under this, if this thing stands, you're going to put me out of business. Actually, he said, I will try my best to figure a way to stay in. But 450 people may well be out of a job because of this. And somewhere else, there's an entrepreneur who wants to start a company like that who says, I can't really start right now until I know what's happening with this thing. So yeah, it has become a tremendous impediment to job creation and growth.
Hello, welcome back to New Mexico.
Hi, thanks.
My name is Chloe Kuntz-Phillips. I'm a marketing major here at the university. My question for you is, you identify insurance portability as one of the reforms needed in this healthcare reform legislation. What would be the legislative changes needed to achieve insurance portability? Okay,
great question. There are a number of different proposals. I had an interesting little meeting. There was a friend of mine who is a scholar in a very conservative think tank, well-known one, Heritage Foundation. And he has proposed something that would work this way. If you could, if you have insurance, you can keep insurance. If you move, another insurer cannot turn you down. Can't say, no, I'm not going to sell it to you, I don't want to, or you're sick, or whatever. But the contingency is you have to keep yourself covered. Because what we're finding, for instance, in some places where we've seen attempts at reform, what people do is this. They don't buy insurance. When they get sick or realize they're about to get sick and need a procedure, they run out, buy insurance, check into the hospital. They get the treatment, which can be thousands, tens of thousands of dollars. Then they drop their insurance policy, which means they're getting a huge amount and paying a little bit in, and the rest of the people out there who are being responsible with their insurance are paying for them. So anyway, my friend there at Heritage said, why not put it this way? You can keep, as long as you keep yourself covered, you can always move, you can go carry your insurance, you can get it, you can't be turned down. If you drop it, that's your choice, not good. Now at the same time, a very liberal, great scholar at Princeton University wrote a similar article. I forget where it was, but his name is Paul Starr, and he essentially proposed the same thing. Before this law passed, he said, folks, we have a serious problem. And again, he was a huge advocate of this law. He said, this individual mandate thing is a problem, and maybe we need to, as soon as it's passed, get busy and shift it over to something where His was a little bit different. His was an opt-out rather than an opt-in. His was, if someone wants to drop it, fine, but make them sit down, think it through. You ask them questions, make them certify, I understand, if I drop my insurance, this is what it means. And then at that point, if they want to drop it, they can't get back into this promise for, I don't know, X number of years. And I got these two scholars, one very right and one very left, in touch with each other. And they were, I think, somewhat surprised that, gee, here's a sort of an interesting bipartisan alternative. Very different from what this law does, and you sort of eliminate all of those IT requirements that I talked about, because the only time I need to know whether you have insurance or whatever is when you go to switch policies. Anyway, that is one way. I'm not advocating it because I'm sure it has its own problems, and when you propose these things, you have long conversations with the pros and the cons, but that's one idea of how it could be done. I mean, we're also, we're very much in favor of exchanges, which are part of this law, places, centralized places where you could go and get a policy and move around, and if you think you're someone who's going to be moving around a lot, buy a policy yourself rather than through your employer. If you switch jobs or move locations, you've got your policy through the exchange. Doesn't matter that you've moved your house or moved your job. You've still got the policy. So those are just a couple of the ideas that we think need to be on the table at least.
Dr. Bob, I'm going to introduce you to Dr. Jim Peach, who's a Regents professor here. We have 30 of them. They're kind of the creme de la creme of our faculty here. And Dr. Peach will correct me if I'm wrong, but I think he may be the only person I know that's actually read the piece of legislation that you referred to. This is Dr. Jim Peach.
It's nearly 1,000 pages.
If you come to Washington, you'll still be the only person there who's read it, I can assure you.
I read the Stimulus Act. I read TARP. Very few people have done that.
Not much to do down here then.
But, well, it's a way of hiding from the dean. But in all that legislation, did you find anything that you really liked?
Yeah, sure. I could pick and choose things. We like exchanges. I mean, we've actually been rather instrumental in pushing that idea. And there's an area where a lot of our friends on the right are not keen on our support for it, but we think that's a worthy idea and one. And there are different models. Massachusetts has one. I think it's probably a little too intrusive and tries to do too many things. Utah has a very different model that, again, we're just beginning to see whether it's going to succeed or not. It's got some interesting ideas. So yeah, we think that's a pretty good idea. We certainly like the idea of having the capability of people with pre-existing conditions be able to secure health insurance. That's important. We think that this law established a tremendously cumbersome mechanism for doing it because when you get down to it, the number of people in America who are really in that situation, if you break down who's uninsured, you get about a quarter who are not or are neither citizens nor permanent residents. We've got about a quarter of them are young invincibles, 20 and 30 somethings who say, I'm perfectly healthy, I don't need to buy insurance, I'd rather buy something else. You've got another 1/4 of them are people who actually, while they're technically uninsured, they are qualified for Medicaid, the program for lower income people, and they just haven't bothered to sign up for it for one reason or another. And I guess I could blame the government as much for making it a very cumbersome process to do that. But if they get sick, all they have to do is go down, sign it, and it's retroactive. About 1/4 of them, maybe 10 to 12 million people, are the ones who really have a serious problem, either for health or income reasons, and that's who we should be going after. And instead, we've overturned the entire healthcare system and thrown it into uncertainty to deal with that problem.
Okay, Dr. Bob, Dr. Peach, we're down to soundbite territory. We're about to end. A quick question and a quick answer.
Quick question. Among the many members of NFIB, many of them have to be small businesses who are healthcare providers. Do they give you a different story than the rest of industry?
You know, I don't know that we've actually pulled that polling data out. I get it, interestingly, from my students, again, many of whom are small business owners who own a medical practice or such. And I don't think a semester goes by that I don't get some startling comment. I had one physician in a pretty good field. He said, I no longer can cover my nurses and office people. I used to buy them insurance. I can't anymore because I would not make a profit at this point. I also had one student, I teach in the School of Nursing at University of Virginia, and I made a comment. I said, I think you guys may be the smart ones going to nursing instead of medicine, given some of the things that are happening. Don't take that as gospel. It's just I think there is some truth to that, but I also knew my audience. And one of them said, it's funny you should say it, because she said, my husband is a CPA, and he has a number of medical practices as clients, and what he's discovered is some of them, the nurses are earning more than the doctor is earning at this point. So, yeah, it's a problem for them too. I think it's going to be the end of a lot of small practices.
Dr. Bob, I want to thank you for coming to New Mexico State University and the Domenici Institute to discuss this issue. I want to thank the National Federation of Independent Business and your colleagues here in New Mexico. We hope you do come back. Again, the offer to come back to university is always open. We'd love to have you. And the next time we're going to get you back here when our students, more of our students are around. We're kind of in between semesters. We ask our ambassadors to come in a little early and participate in this program. We're delighted to have you. Enjoyed your presentation, and thank you for the work you're doing on healthcare reform.
Thank you so much, and thanks to all of you.